Fantastic, welcome. It's a real pleasure to be here. My name is George Dalal and I am part of Kaleidoscope Health and Care and I have the role of being your facilitator today to explore rethinking medicine. So rethinking medicine is about enabling doctors to have better conversations with their patients and acknowledging that a good life is more than just about the best available medicine. And today we're going to be bringing that to life for a real clinical case and exploring some of the themes that it surfaces. To do that today, I'm joined with a fantastic panel, both here in the studio and joining us remotely. I'm going to ask our panelists to introduce themselves. If I may start with Jocelyn.
Oh, hello, I'm Jocelyn Cornwell and I'm the founder of a charity called the Point of Care Foundation, which works in the health service, trying to spread various interventions that humanise healthcare.
That's it. Thank you, Jocelyn. And Alf Collins.
So I'm Alf. I'm currently National Clinical Director for Personalised Care at NHS England and NHS Improvement. But I spent 25 years of my life as a community pain management specialist.
Thank you, Alf. And joining us remotely, we have Martin Marshall.
Hi to everybody, I'm Martin Marshall. I'm a GP in East London. I'm chair of the Royal College of General Practitioners and I'm an academic at UCL.
Thank you, Martin. And Louisa Pettigrew.
Hi everyone, my name is Louisa Pettigrew. I'm a salaried GP in Barnet, London. I'm also doing a PhD and I'm clinical director for PCN in Barnet.
Fantastic, thank you all. And backstage we have Peter, our webinar manager, who'll be helping with the logistics. I may refer to him a little bit later on. This is going to be a very interactive webinar and we're going to be asking for your reflections, your advice, and your opinions in just a short while. There'll be three main ways that you can participate. So I will just briefly run through those. Firstly, you can use the Ask a Question feature on the GoToWebinar interface. So you do that by pressing the question pane or question button rather. You can also email in your questions via hello@casecopehealth.org.uk. hello@casecopehealth.org.uk. And finally, you can use Twitter. We'll be using the Rethinking Medicine hashtag, or you can tweet at us via the @rethinking_med handle. So the Rethinking Medicine hashtag or @rethinking_med handle. You can use any or all of those per your preference. And we're also going to be recording this webinar. So if you get cut off or if you're unavailable for any reason during it, you can see it posted on our website afterwards. And we're going to be sending out a link to all participants. So with that, let me hand over to Martin to explain why we're rethinking medicine.
Thank you very much, George. So a quick introduction to Rethinking Medicine for those of you who might not be familiar with it. So let's start with the medical model. The medical model, with its focus on the diagnosis and treatment of disease, has achieved amazing things throughout history and will continue to do so. As a consequence of what we're taught at medical school, the medical model, people live longer and they live healthier lives than they've ever done in history. But in many ways, therein lies a problem. Medical model is so good, there's a temptation to overuse it. And when it's overused or when it's used inappropriately, it can be wasteful and it can even be dangerous. And it's for this reason that we're seeing a growing number of doctors, I think it's fair to say, who are exploring other ways to practice medicine. And that's essentially what rethinking medicine is. Let me give some examples. We're seeing a growing number of doctors who are shifting from the model of doctor as expert, making decisions for patients, to recognizing the desire of patients to be more involved and to bring their expertise to the table, if you like, to share the decision-making process. And there's lots of evidence that patients, when they're involved in decision-making, often choose the less interventionist option than doctors would do. We're also seeing a growing number of doctors who are engaging with the overdiagnosis and the overtreatment agenda, who are using research evidence to positively challenge some of the common interventions that we use where there's evidence that they can be damaging. We're also seeing a growing number of doctors who are engaging with the social determinants of health, and that's hardly surprising given the evidence that, depending on how you measure it, somewhere between 70 and 90% of our health is related to things that operate outside the health service. Our health behaviors, our education, our wealth, particularly the distribution or the maldistribution of education and wealth, our environment. And that's why a growing number of doctors are getting interested in social prescribing as an intervention in place of traditional medical interventions. And finally, we're seeing a growing number of doctors who, if you like, are moving beyond their traditional clinical role, their focus on patients or on populations, to influence how services are delivered, to influence how services can be improved and how they can be redesigned. So the Rethinking Medicine is not really a program, it's not even a thing in many ways. It's a way of thinking, and perhaps more importantly, it's a practical way of doing things. It simply describes what doctors are doing, many doctors are doing right now. A growing number of people are getting involved in the Rethinking Medicine initiative. We've got a website, we're holding a conference in March, we've run a series of webinars, of blogs, social media activities. We're framing a number of mainstream activities like the evidence-based intervention program as an example of Rethinking Medicine. The webinar today is in some ways a new experiment, a new venture for us as a team. We recognize that Rethinking Medicine is a cultural challenge. It's countercultural in many ways, certainly to the way that we're trained as doctors. So how do we expose that cultural challenge? One of the ways of doing that is to use what Balint devised way back in the 1950s and 1960s as a way of challenging strong cultures. And that's really what this webinar is about today. It's going to be interesting to see if it works. George, back to you.
And thank you, Martin. That's a fantastic setup. So, yeah, our aims today are to explore some of the themes that Martin raised by examining a specific clinical case, and as a result, explore the current culture in which we operate and how it influences practice. So to do this, as Martin said, we're going to be adapting the Balint group method. That's Balint spelled B-A-L-I-N-T. Which, as Martin mentioned, dates back to the 1950s, but has had somewhat of a recent revival in times with lots of people now using it to inform their training and their practice. So the method consists of a case presentation followed by a general discussion with the emphasis on the emotional content of the doctor and the patient relationship. So today we're adapting that approach and going to be structuring our conversation using the following format. First, we'll be hearing from Alf as our presenting doctor, who's going to be sharing a particularly challenging case. Secondly, we'll offer our panelists the opportunity to ask clarifying questions. We'll then take reflections on the case and the issues it raises from our panelists, and then we'll open it up to everyone participating virtually, welcoming both questions and reflections. We'll then offer Alf and the other panelists the chance to reflect on some of that discussion and offer some closing responses and reflections. As Martin said, this is very much a test, and in the spirit of improvement, we're really going to be welcoming feedback and feedback on the approach. And when the webinar ends, hopefully a survey will pop up. Will only take you about a minute to respond, and we're going to be using that information to design future webinars. So please do take a moment to complete it. So without further ado, I'm going to hand over to Alf. So Peter, if I could ask you to progress to Alf's slides, and then Alf, if you could explain the case.
George, thank you. As I explained at the beginning of this, this webinar, I was a community pain management specialist for the best part of 25, 26 years, working to support people to live well with pain rather than to take their pain away. So that was the philosophy of the service I worked in. Much of my work was actually working alongside and with primary care teams. And I'm going to share with you now one example of a particular case that came to mind, a particular person that came to mind when I started thinking about this. We'll call her Paula. I stopped clinical practice a year ago, but I phoned up the clinical team last week, and Paula is still in pretty much the same position as now as I'm going to describe to you from my recollections of her from last year. So let's think a little bit more about Paula. So she's 49 years old, and she's single. She's had quite a tough life. She was in care as a child, and really struggled as a care leaver, and actually has struggled in a lot of her life over the last few years. She's been a frequent attender at a number of practices in the West Country. She's moved around a lot. And part of that moving around has been that she's been generally quite dissatisfied with the care that she's received. She doesn't tend to hold down jobs very much because of that flitting lifestyle, or as part of that flitting lifestyle. And in terms of her clinical story, for many years, she's been known to have anxiety and depression. She's seen a number of psychologists and psychiatrists over the years, but little has really shifted for her. Her quality of life has remained poor. She's continued to feel low, to feel quite anxious. She's got a number of not just medical conditions, but bodily symptoms and complaints. She's seen a rheumatologist, or a number of rheumatologists actually, and has been described as having fibromyalgia, which is pain over multiple sites in the body, caused in part by a very sensitive nervous system, a so-called vigilance in the nervous system. She's seen a gastroenterologist, and she's got irritable bowel syndrome, and fibromyalgia and irritable bowel syndrome do tend to go together. She's also got some bladder problems, and she's currently seen a few urologists about that, but he's currently, the question is whether she needs to go and see another urologist, because it's unclear whether she has indeed a bladder problem, or whether it's again part of her overall fibromyalgia problem. She's quite overweight, and she's got diabetes, and that's poorly controlled as well. Her blood pressure is not that well controlled, and her blood lipids suggest that she may well be at risk of a cardiovascular event. So hopefully you're getting a picture now of someone who's, presenting in quite a complex way. She does get chest pain, and again, is that part of her fibromyalgia, or could it be a cardiac event? It certainly doesn't sound as though it's angina. So what the primary care team have done is actually to resist referring her on to a cardiologist, because it really doesn't sound cardiac at all, despite the fact that she does have, a cardiac risk profile. So to go into more detail about the way she presents, she comes into the surgery pretty often with different complaints, her joints, her bladder, her bowels, her chest, her back, her neck. She's often quite upset and quite angry that nothing's being done. And she continues to ask for further referrals to other specialist teams. She's convinced that many of her underlying problems aren't irritable bowel or fibromyalgia, but there must be something specific that's there that can be treated. She continues to see the urologists on occasion. They're thinking about sending her to a regional centre. Reading between the lines in the letters, there's a kind of feeling that the urologists themselves don't seem to think it's the right thing to do. There's a sense in which they're kind of slightly at a loss as to what to do next. So kind of pulling it all together, and Paula was the kind of person that I would see quite a lot of in my clinical job. My sort of sense was that, or our sense as a team was that we should be working to coordinate and rationalize her care, help her make sense of what it was all about. There was also a sense in which many of us wanted to resist yet more onward referrals. But part of the challenge we saw is that in resisting that temptation to refer her on, Paula was tending to see lots and lots of other specialists in secondary care anyway, because she'd just go to A&E. Summing it all up, in many senses, Paula is a kind of a, as I've said, that the sort of person that I would see a lot in my own practice. But there was a sense in which actually many of us were feeling quite self-doubting as a team about whether we were taking the right course of action or not. What else could we do? What more could we do? What less could we do? What different could we do? And I think we very much felt trapped in a dilemma. You know, Paula's got a range of medical problems and a range of symptoms and concerns, many of which are related to her mental health, but she's absolutely resisted, you know, psychologizing her problems. You know, for her, they are real physical problems, and you know, for her, there must be a fix, something that can be done. And as I've written here, frankly, the primary care team really did feel at their wits' end with her as to know what to do and how to move forward to support her to live well. And it kind of felt as though, you know, the kind of a over reliance on the medical model was kind of part of the problem, a big part of the problem. So to sum it up, you know, there was a real sense of what do we do? Do we refer on to reassure her she doesn't have medical conditions that are treatable, or because the problem with that, of course, would be that you're going to find treatable conditions if you do lots and lots of tests. But of course, by not referring on, that wasn't working either. So a really significant dilemma. Paula suffering. Frankly, many members of the primary care team suffering as well in a very different way, but certainly not feeling as though they were doing a really good job. And as I've written here, often feeling at their wits' end. As I say, to sum up, I rang them back at the end of last week, you know, just to see if anything has changed, and nothing really has. So there's Paula, there's her story, there's the story of how the system tried hard to work with her effectively, and you know, the dilemma continues to be a real problem. Back to you, George.
Thank you, Alf. A really relatable case that sadly I can see from some of the comments that have come through already is very similar to many of the issues that some of the clinicians joining us today are grappling with. I'm going to take a few clarifying questions from our panelists, just really seeking not to offer opinions on what to be done, but just to get a little bit more information perhaps about the case and from Alf. So if we go to Jocelyn first.
Thank you. Fascinating story about this person. As I listened to you, Alf, I just had so many questions about who Paula is that, and I guess the first ones that came to my mind was who's she close to? Does she have any family? You said she's been brought up in care.
Yeah.
Does she have any friends? Does she have any pets? What makes up her life in terms of relationship?
Yeah, brilliant questions, Jocelyn. So my sense of Paula is that she does have quite a narrow kind of set of relationships. She lives on her own. I don't think she has pets. As a care leaver, you know, she doesn't have a kind of a family structure within which she's held. She does live alone, and my sense is that she's a very lonely person who kind of wanders around the world in her own sphere. Yeah.
Can I ask any more? Or
Yeah,
do you want to go?
one more and then we'll go to the other panelists.
You said she'd had a difficult life, and you said she was in care and she left care badly, I think.
Yeah.
what does that mean? What does having a difficult life mean? What does leaving care badly mean? What do we know about her, how old she was, why she was in care, what her circumstances were when she left?
Yeah. So I mean, I do know that she'd been abused as a child. So you know, for me, the formulation, because I work alongside psychologists a lot, the formulation was, you know, adverse childhood events leading to a heightened sense of vigilance and anxiety. Why would you not be on the lookout for the next trauma if you've suffered repeated traumas? And that was the kind of formulation that we shared with trauma with Paula. Why would you not feel like this given what happened to you? But she still found it difficult to figure out how and why it was, or it might be the case that those traumas, significant traumas through childhood, might be part of her overall presentation now. She couldn't get that, despite us kind of presenting it to her in a number of different ways.
Great questions. Let me go to Louisa next. Do you have any clarifying questions?
So thanks for sharing that case, Alf. The first questions that came to mind were the same ones that Jocelyn raised about, you know, who's her family? Does she have family? Does she have friends around? I guess maybe going into a bit more depth is, what is she doing with herself most days? How is she keeping herself busy? And from the sort of primary care end, who's seeing her? Is it same doctor, different doctors? What's going on in terms of that?
So one of the things we did do was try, insofar as we could, to make sure that she just saw one clinician. To my mind, there's a kind of pros and cons to that. You know, the one clinician who was seeing her was actually feeling quite distressed themselves, and they got into quite a kind of a loop of not necessarily productive conversations. So that there was that element. Yes, care continuity and coordination is incredibly important. There's something for me about caring for the clinician as well in those cases, but also recognizing that those kind of loops are not necessarily helpful. Conversations can just become a habit. So that was one question. What was your other question? I think you had another one.
So just going into a bit more depth about how she was keeping herself busy. You said that she had various jobs, but she had struggled to keep them down. What did she do? And was there a link between how frequently she attended and her jobs, or other things going on in her life?
Yeah, so I don't have a full notes here, and some of this is now recollection rather than fact. But my sense was, you know, she'd moved through a number of kind of menial jobs, really. I'm not sure what the relationships between her employment status was and, you know, her frequency of attendance. My guess would be that there would be some sort of relationship there. I mean, one thing I always, when I worked in primary care, was really hot on was just inviting people to tell their story. You know, what's a normal day like? And normal days for her were really not great. I mean, very, very narrow indeed. Sitting in the flat, not going out, racked with pain, feeling anxious. You know, really quite an enclosed life, actually.
Thank you, Louisa. Martin, any clarifying questions that you'd like to ask?
Yeah, just very quickly, for clarification. First one, do you know how well her caregivers communicated with each other? You say that she was registered with lots of different practices. Did they talk to each other? Was there good communication between the hospital and the practices? Did she go to other hospitals? You say she was very mobile geographically.
Martin, it was poor. You know, it really was poor. Because of the fact that, I mean, it didn't feel as though there was enough coordination, and you know, we were trying to put that in place. My sense was that previous caregivers had tried to do the same. She was on a boundary between two different hospitals, and again, that kind of transfer of information from secondary care to primary care, but between secondary care providers, was a very significant issue. I'm absolutely convinced it could have been much, much, much better than it was. Yeah.
Okay. My second question related to whether there are any clinicians who were looking after her, working with her, whose heart didn't sink when you described this story. Is there anybody who saw her as an interesting challenge even? Or did everybody think, what on earth are we going to do here?
I think nearly everybody did, Martin, and I have to say, she represents, as I've said a couple of times, the sort of person that I used to really enjoy working with. And my sense was that, I mean, I felt it was a real challenge for me personally. Actually, that's why I brought this to the table here.
So even your heart sank.
Yeah, well, yeah, and it was partly because, I mean, I didn't feel I had the requisite skills, but I just don't think there was enough coordination between probably 20, 30, 40 different clinicians who were seeing her to provide her with that seamless, coordinated approach that she so desperately needed. I felt I was just one of the cogs in a number of wheels that weren't really meshing, actually.
Great. Thank you all. So I think I think what we'll do is we'll transition to what in Balin terms is called the pushback phase, where Alf takes kind of a metaphorical step back, and we get to hear the opinions of some of the people online. But we'll start with our panelists here around possible reflections and possible suggestions around how to improve the situation and offer support either for Paula or the team caring for her. So maybe we'll start with we'll stay with you, Martin, go to you, Martin, and then hear from Louisa and Jocelyn, and then we'll open it up for some more reflections. And I can see there's some coming through, so thank you, and please keep them coming if you're one of our virtual participants.
So just some quick thoughts. And the way you told the story, I mean, you could actually see your body shrinking, never mind your heart. You know, it is what she is, one of those patients that does make people feel impotent in so many ways. And I guess, you know, one of the ways of handling it is to stop trying to do something for her, which I'm sure, you know, many of her clinicians did do. All you are is a listening ear, and sometimes that can be very helpful. The problem with that as a clinician, of course, is something will go wrong. She will develop. Her concerns will be verified at some stage or other. Was it Spike Milligan who's had his epitaph? What is his epitaph? There, I told you I was ill, on his gravestone. You know, people will get ill, and that makes us anxious when we know that we will miss some kind of physical disease, and the implications of doing that, the fact that it makes you feel bad. So I guess that's you know, that's something that we have to live with, maybe. I'm going to stop there actually, because there'll be other opportunities to feed in.
Great, thank you, Martin. Louisa.
So I guess to say that I recognise Paula. I've seen Paula's before, and I feel the heart sink too as a clinician. I guess my reflections are just about how unprepared we are often as GPs and as a system to manage or help people like Paula. I've sort of written sort of a list here of things, but I can see challenges at practice level, at local service level, at system level with the hospitals, so on, or with the carer system, social care, and sort of the social determinants of health. You know, as a clinician, as a GP at the practice level, there's these issues of continuity of care, which are good, but sometimes that you, like you said, it's interesting reflection of getting caught in this cycle. That the clinician also needs help to break involve, and might feel a bit isolated, because I suspect it's the kind of patient that other GPs try and avoid. So often they do find recourse with a kind ear GP that's willing to give a bit more time to them. And just a reflection that I just don't think our GP training often prepares enough to deal with the non-clinical stuff, the somatization issues, stuff around the social determinants of health. I think we are trained to do something, and even though there's more awareness of these other issues, I still don't think that GP training is geared enough towards that to do that. I think, you know, there's a lack of access to psychological services. I think that's a big challenge. If I wanted to refer somebody like Paula to a proper service, somebody like you, Alf, I don't think we've got one of you nearby. You know, mental health services, we've got months waiting list. They've got very limited time. There's no fibromyalgia services to refer people to in the near future. ME services, these are kind of MDT type services that you want to be there to work with you to support Paul, and they're difficult to access. You know, system problems in A&E, you always have a junior doctor at the front end. Inevitably what they want to do is investigate and exclude, but this gets repeated a million times with patients like that, so there's not good communication, and that causes a problem too. Yeah, I see. I recognise the challenges, and I just don't think that we're set up to deal with them properly and provide Paula with the type of help that she needs.
Thank you, Lisa. Jocelyn.
Well, unlike all the other people in this discussion, I'm not a doctor. So, well, I'm an academic doctor, not a clinical doctor. I'm a sociologist, and so when I read first of all, Alf's written account, because he shared it with us first about Paula, I thought all we know about is Paula's deficits. We know what she doesn't have. We don't know anything about what she has. I don't know, a little bit like the question that Louisa was asking about, I know nothing about what gives her pleasure, what she enjoys, and I actually know nothing about what she thinks the problem is. I think you said something really interesting, Alf, when you were introducing her to us. You said she thinks there's something deeper that explains her problems. And I think you think there's something deeper that explains her problems too. It's just that your language, and you don't know what language she uses for that, perhaps. And I was thinking along those lines and thinking how she needs somebody to get alongside her, not assess her. And I was thinking about some of the other services in, or sort of, services, utilities that she might have relationships with, including housing, and where she lives, you know, neighbourhood type groups and so on, and whether, because I feel the burden so intensely that you're suffering and that your colleagues are suffering of not being able to help her, and worrying actually about her physical problems when so much seems to be emotional and relational. And yet at the same time as worrying about her physical problems, in a way you're not really taking them seriously, because you're worried about her being investigated. And I was thinking, I wonder which one of those matters most to her now when she comes in at this moment. And what if somebody actually took that, just one of them, really seriously? So those were the sort of thoughts I had.
Brilliant. That's a great, really interesting reflection. Thank you. I think maybe I'll just share one or two that have come through from the audience, and then maybe I will come back to you, Al, from reflections and go around once more. So one question around, why do you think she might resist the mental health team? And was there a difficult experience or bad experience, and might there be other services that could help? And then another question that's similar to what Jocelyn was saying around, what are some activities that she might enjoy? Does she have anyone to love? Is there anything she's looking forward to? This idea of hope, and then that question is kind of bringing it that there's some conversations on Twitter around GPs and screening, and I think it kind of relates to some of that as well. And then another question that maybe we'll pick up at this stage as well is there a feeling amongst the team and your former colleagues that she was a difficult patient, however we want to define that, and that might perhaps touch on some of what Louisa was saying about a lack of training and lack of response. And someone else commented, there's no such things as heart sink patients, just heart sunk doctors. and you know, I think that's kind of chiming in here and with what you speak. So maybe I'll give you the opportunity to come back on maybe some of those comments from either the panelists and or the participants.
I think the first thing to say is, if only we'd had this conversation in the team. Actually, a year or so ago, we didn't. So this is just remarkably useful, actually helpful. The first question I want to pick up is, why did she resist seeing the mental health team? I think there's a fairly straightforward answer to that. It's twofold. First of all, her experiences of the mental health team have been poor over the years. Nothing had really shifted for her. And secondly, you know, from her perspective, she had real physical problems that she wanted the health system to sort out for her. I'm paraphrasing, but that's the kind of bottom line, really. So there was a real resistance, an absolute resistance to seeing them. Again, I worked with 2 clinical psychologists, and she could have seen them within a week, but she just didn't want to, for the reasons I've talked about. In terms of difficult patients, yes, of course, this isn't a language that any of us would tend to use consciously, but actually she was seen by, I think, many of the team as being difficult, primarily, I think, because it made them feel bad, because they felt helpless themselves. And I do agree with one of the comments, which is, you know, there is no such thing as heart sink patients. There is such a thing as heart sunk doctors. And I think that was the way people did feel in the practice where I was working, very much. You know, this is triggering a whole heap of really challenging, difficult emotions for me as a clinician and for us as a clinical team, because nothing is actually changing or improving here. Thank you, George. Back to you.
There's another comment that's come in that's quite interesting as well. It's around, you know, given that the medical team, you know, isn't having much success, it's this idea of peer support. And, you know, perhaps could she be given some kind of intervention by people who would live with other similar long-term conditions? Is such a thing even available? And then the commenter makes a point which she probably wouldn't attend. And has she been offered any kind of health coaching or self-management support, motivational interviewing, that kind of thing?
So yeah, I mean, I did motivational interviewing and health coaching. So we took a, you know, I took that approach with her when I saw, I was very much trying to support the primary care team to deliver these interventions rather than me being just yet another person that saw her. So we very much did try to take an asset-based approach with her. What we didn't do was provide her, I think, with adequate peer support. I think that's a great idea. My sense was that we didn't have that kind of formed system in the practice enough for us to have said, yes, why doesn't she see, you know, Gwendolyn, who's fantastic at this stuff. I think that might well have really helped, but we didn't have it in the practice in a formed way. Oh, this is good, isn't it?
Alf, and we'll come to Martin and Louisa again, give you the opportunity to come back in just a second. I'm just not sure you picked up on, you know, did she have anything that she was looking forward to, any activities that she enjoyed, or not that you managed to surface?
Not that we I mean, that was the, again, I probably had contact with her 6-7 times myself, and I did employ that approach. Tell me about a normal day, and you know, it was very much pain. Her horizons were quite limited, actually, I think is the kind of phrase that comes to mind. No sense that she could live other than in the moment, and in that moment she was living in pain and with fear and anxiety. Yeah, I mean, terrible for her, actually. Yeah.
Thank you. Martin, are you going to come in?
Yeah, just a question for Alf, which might sound a bit rude, and I'm sorry if it does, Alf, but what she wanted to see possibly is a serious disease specialist in a hospital.
Yeah.
and instead she saw a pain management consultant in the community.
Yeah.
Is it possible that the referral to you was part of the problem for her? That was rude, wasn't it?
No, but it's a brilliant question, Martin. You know, part of me just thinks the dilemma. Why don't we just make sure that she sees the best orthopedic surgeon, the best urologist, the best GI specialist, and you know, they can all say, I'm just going to be really, they can all say, Paula, we can't fix it. Yeah, that would be one course of action that might really have helped. The possible downside to that is that they would then refer to their mate up the road and or do a battery of tests, some of which would come back, you know, with possibly false positive results. So we didn't do it, but wouldn't it have been interesting if we had?
We were able to sit down with her when she had seen disease-based specialists in hospital. We were able to sit down with her and in detail go through the findings and find out whether she was content with what they'd said.
So I did do that. I'm thinking back now, so this is a little time ago. I did do that for her bladder problems and explaining her bladder problems as possibly related to a very sensitive nervous system that was amplifying the messages from her bladder. So, you know, she just didn't buy that. She just didn't buy that as a you know, when she's seen other specialists that have said other stuff, then it's a tough one. It's a tough one.
Yeah. So George, I wanted to make some comments on how this case relates to Rethinking Medicine, my description of Rethinking Medicine earlier. Do you want me to do that now, or do you want to go around the rest of the group to see if there's any more issues about the specific case?
Well, maybe I'll give Louisa the opportunity to come in and just no pressure at all, Louisa, but if you had other things that you wanted to say, please do.
I guess I was just wondering how she came across, and when she went to see a specialist for the first time, how do you think the specialist approached her? Because there's a risk that you write a patient off already if you see long records, or there's a particular way that they communicate that you know, everything's pointing to some element of somatization and social determinants of health here, but we don't really understand how the mind affects the body, and there's always a question of whether there's something genuinely could be going on that is being missed. So I understand how difficult it is. Just wondering how she came across and whether things could be genuinely being missed with her.
In my experience of working with her, she often came across as really quite angry.
Angry.
Yeah, and a lot of that was driven by the fact that she felt that people weren't taking her seriously, and were kind of fobbing her off. And you know, Martin, getting her to see kind of pseudo experts rather than the real deal in the teaching hospital up the road. And I do think, Louisa, I think there's something in the fact that she had notes. I mean, they came into the room. I mean, they were literally that thick. You can't see the top of my hand. Reams and reams and reams of notes. And of course, as any clinician looks at those and thinks, oh goodness, you know, immediately from the off, you'd love to think we were really objective. You see notes like that and your mind kind of moves into one particular space, it seems to me, actually. Yeah. I think all of this is compounding her problems.
Yeah.
You
know? Was there a feeling then from her that almost she'd been written off, and she was angry at that feeling that she was just in this cycle of being almost written off by doctors and going through the process?
Yeah.
Never really having somebody engaged at the level that she wanted.
Yeah.
Interesting, Justin.
Was it sort of reflecting on the whole process?
Maybe we'll go to that in just a minute.
Yeah, okay.
And anything else about the case?
Well, I suppose I was thinking, somebody asked a question about continuity and relationships building over time. And I was thinking about this succession of appointments that she has, including with you, or in the past. I was wondering whether it was possible within the context that any of you work to get alongside a patient and say, in order to help you, I really need to get to know you over a period of time.
Yeah.
And I need, this isn't going to happen quickly, but I will see you regularly over this number of months. And during that time, what I'd like to do is get you to help me understand more about how you see what's going on. And I'm absolutely committed to getting secondary help when it's needed, you know, actually being much more upfront about what you can and can't do. And as it were, trying to make a contract with somebody about what's on offer. Because the way I see it, we, the general public, behave in the way that we are schooled to behave by doctors as much as anybody else. And the fact is that as other services have diminished, the GP and primary care team are the only place left, apart from A&E, to which you can bring problems. And if you're going to bring them through that door, you know you've got to have a medical label attached to them. So she's kind of playing the game as well, it seems to me. And she's finding symptoms, she's finding physical problems because she knows that's what you're about. You know, we are all being schooled in how to use services all the time. And somebody's got to break out of that particular mold if we want to rethink medicine and say, actually, we're very limited in what we can offer you as a pain specialist. But what I really can do is help you to find your way around the system and help you to think, but I need to understand you. It's all that pie in the sky. And
well, no, as I'm listening to that, I'm thinking, why didn't we do that? I mean, I think I did compound the problem actually in retrospect by essentially me trying to sort of support the primary care team rather than me saying, actually, why don't I step into that role myself? Because I've been trained in health coaching and psychological approaches. So, you know, looking at it again, I don't think I did the very best for her. You do remind me, actually, that there was a fantastic paper by a psychologist called Peter Salmon called the somatizing effect of the clinical consultation, which absolutely confirms what you say, which is that patients present to us with medical symptoms because they feel that's the only way they're going to get heard. Yeah. I agree with everything you said. Thank you.
There's a brilliant paper by a guy called Phil Strong, which was about taking his animal to the vet and knowing all the questions in advance that the vet would need to have answered, and how he just thought, what I must prepare myself to fit with what the vet can offer.
I'll just make one other reflection. That's okay. I don't think it's come up. It's about the 10-minute consultation, and one of the biggest challenges in general practice, I imagine Alf, you might have had more than 10 minutes, but the biggest challenge I see for GPs caring for somebody like Paula is having 10 minutes to do it in. And what happens in 10 minutes is the system is set up for you to medicalise somebody and not open what might be considered a can of worms by some, and spend that time actually engaging your own brain in identifying what's the problem, trying to solve it. And in 10 minutes it's enough to do a referral, do some blood tests, which is probably not the best approach, but it ticks a box and covers clinicians back from a medical legal perspective, but might not be the right thing to do. And so the system needs to be set up to give GPs enough time to be able to give Paula the time that she needs, and actually give GPs to attend meetings where cases like Paula are discussed, and a plan is made to support patients like Paula or anybody else with complex conditions, whether it be multimorbidity or mental health or whatever else. And it's currently just not the case.
Thank you, Louisa, and thank you everyone for the questions. I think what I'll do now is turn back to Alf and see if there's any final questions around Paula and this case specifically, and then maybe we'll go to Martin and think about some of the system questions this relates, 10-minute appointments, lack of training, and how those relate to some of the themes of rethinking medicine. So maybe Alf, if you want to maybe think about or explore just what you wish maybe you would have done differently having had this conversation, or anything else about Paula's case in particular.
So I've written down a few phrases that various people have brought in here. One was we should resist doing stuff where we're trained to do something. So there's something in this about us as fixers, clinicians, that I think we need to pay more attention to, because if we can't fix something, that makes us feel frustrated, makes us feel very negative, often towards the person we can't fix. And I just don't think that's helpful at all. So clinician as fixer, I think, is part of the problem that we have here. Another phrase that I wrote down is that what she really needed, and Jocelyn said this, was someone to work alongside her and not assess her. And yeah, absolutely, completely agree with that. And I think in trying to share the burden with the clinical team, I don't think I helped at all. I could have got alongside her and not assessed her. What I tried to do was help the clinical team fulfill their role more effectively and more confidently. And in doing so, I created more of a problem. So I just wish I'd had these kind of conversations, as I say, 2 years ago. Thank you.
Thank you. Martin, perhaps I'll turn to you now to either reflect on the process and think about some of the implications.
Yeah, so I thought it might be helpful just to draw some parallels between this case and my earlier description of what Rethinking Medicine's about. It does feel to me as if this is a really good example of the need to rethink medicine, of how we've got ourselves into a place where we feel medicine must have the answer. We feel, health professionals and the patient feels, medicine must have the answer if only we try hard enough. And the reality is quite possibly it doesn't have the answer. The anxiety always being, are we missing something? And I've, in the not too distant past, looked after somebody who had very similar symptoms to the one that we're describing here, that went on for years and years. She was a very forthright person who used to get into enormous arguments with her GPs and with her specialists. She was labelled as being personality disordered. And about 20 plus years down the line, she was given a diagnosis of a connective tissue disorder called Ehlers-Danlos syndrome, which actually did explain all of her symptoms. And when she got that diagnosis, she was transformed almost overnight to being a completely different person. So the anxiety in our head all the time is, are we missing something that's very real out there? I think that's an anxiety that perhaps we just have to live with, because this particular case, I think, exemplifies the four things that I said clinicians were engaging with outside the traditional model of medicine. So first of all, the shared decision-making process. It's very clear that there wasn't a connection between this patient and her caregivers. And I think there must always be ways of finding some kind of connection. Some connections will be better than others. There must always be ways of finding a way. So having skills to develop those connections is really important part of what Rethinking Medicine is about. The second area was over medicalization. Very clear example here of, well, I think, Jocelyn, maybe you're right. Maybe there are some examples of under medicalization here, but actually there are definitely some examples of over medicalization here, not getting the right balance, not using the medical model where it really adds value, using it inappropriately. So another example of where we as health professionals need to be better trained, to have more experience in thinking more broadly than traditional medical model. The third example is around social determinants, and Alf, I think you've described perfectly the consequences of an unhappy start to life. There's so much evidence about this, which then leads to health, mental and physical health problems further down the line. So again, if we don't engage with that, if we don't understand that as health professionals, then there's a real problem. Another reason for rethinking medicine. And then the final thing, which I think Louise has raised on a number of occasions, is the extent to which the health system is not adequately designed to support patients like this. In fact, the exact opposite. The health system with a 10-minute rushed consultation in general practice, the lack of access to larger multidisciplinary skills that might be out there. The health system is actually designed to make these kind of situations worse rather than better. So all the more reason for health professionals getting engaged with system redesign and system improvement so that we can design a system that meets the needs of these kind of patients. So it feels to me as if this is a really good way of surfacing all the reasons that we think rethinking medicine is necessary.
Thank you, Martin. So we're coming up to the top of the hour. Let me offer Louisa and Jocelyn the chance to share just the closing reflection.
Me?
Yes, let's go Justin first.
Well, I guess the other thing that I feel we haven't really talked much about is how clinicians get support for dealing with people like Paula. You all recognise Paula in some way as, it seems to me that actually confronting her life problems and your own difficulty solving them for her, which is what you want to do, is very painful. And if you really open yourself to her problems that are insolvable, it's enormously overwhelming. And that therefore it's so important to think, well, if we want to rethink medicine, we've got to have a part of that thinking very seriously about what kind of ongoing support, emotional and otherwise, clinicians are going to need if they're really going to attend to patients in a different way.
Yeah. Thank you. Louisa, any final comments?
So I guess just to reflect that I really relate with the case, and from a clinician's perspective, what I would like would be, I've just listed the 3 T's: more time to help patients like Paula or other patients with complex conditions, more training to understand issues around somatization and other complex conditions. That includes the medical things like Ehlers-Danlos and so on that might surface down the line. And a team, and that means sort of a wider team than the GP practice. So that means, you know, better communication with the housing, better communication with secondary care services, better communication with voluntary sectors. And with PCNs emerging, it might be the case that through a new sort of system in general practice, we can develop better links with the community to have that communication and other services in place. So those are reflections about the direction of what's needed in the system to help support clinicians to support patients like Paula that present.
Thank you, Louisa. Well, sadly, we're running out of time, but if I can thank all the panelists for really thoughtful reflections, and I've really been struck just by the honesty, and thank Alf in particular for presenting the case and also demonstrating the humility to acknowledge that despite your best intentions, perhaps you actually exasperated the situation. And I think that's a really powerful thing there. If I can ask Peter just to pull up the final slide, and we'll just briefly touch on some further ways to get involved. So please do continue the conversation on social media. We have the hashtag Rethinking Medicine and the handle @RethinkingMedicine. We have released just a few more tickets for a national event that we're holding on March the 11th in London, where we'll be picking up many of these themes. We also would have a range of really helpful blogs around how people are rethinking medicine in different parts of the country. There's some really helpful content there that kind of brings rethinking medicine into practice. Encourage you all to have a look at that, and also to submit a blog and tell us around how you're rethinking medicine in your area. We're going to be running 2 more webinars, one in April and one on May. There'll be morning ones. And finally, and I think I touched on this earlier, just to say that this has been a bit of an experiment for us. I found it a really profound conversation, but when you click and when this webinar closes, hopefully there'll be a pop-up offering you the opportunity to give us a little bit of feedback, and we're certainly going to be using that feedback to help us structure those webinars in April and May. So please be as honest as possible in that, and tell us, whether you'd like a similar thing in April or May, or whether we could do something differently. So I think we'll close there just before the end of the hour. Again, a big thank you to everyone for joining, and thank you to our panelists and Alf, the presenting doctor. Thank you, everyone.
Thank you.
Bye.